the wrong slide. Let's see. Here, thanks. First, I want to thank Julio for the invitation to speak here, and it's my privilege to speak on behalf of my colleagues from Uganda and Kenya and the United States, and my co-PIs, Dr. Moses Kamyan and Dr. Elizabeth Bakusi from Uganda and Kenya. So the Search Collaboration is a multinational, multidisciplinary research consortium established in 2010 to test bold community health interventions. Our goal is to inform policymakers on these high-impact community-level health interventions. Our stakeholders are the World Bank, WHO, UNAIDS, PEPFAR, NIH, Gilead, the Ministries of Health of Uganda and Kenya, and institutions UCSF, Makerere, IDRC, KEMRI, and UC Berkeley. This is a little bit repetitive from the prior speakers, but the rationale of our search study that I'm going to describe is that thanks to the 052 study, we know definitively that ART stops transmission at an individual level. However, despite the vote here, and in a more broader community, there still is equipoise about the magnitude of prevention, health, and development benefits conferred by a sustainable and scalable community-level ART delivery for all persons living with HIV. Search informs ART policies and delivery models that will optimize broad health and development outcomes in a setting of limited resources. So these are two main questions that Search will address. First of all, can antiretroviral therapy shut down new HIV infections with the test and treat strategy? And if so, what are the secondary gains, the beneficial effects on maternal-child health, tuberculosis, education, and household earning power? What is the best way to do it, and what would it cost? And secondly, we are interested in informing the question if can efficient HIV chronic care models be adapted to established care for other chronic diseases such as diabetes and hypertension. So the study design of the Search study is a clustered community randomized study. It's going to be conducted, or it's being conducted in Uganda and Kenya. There are 32 pair-matched communities of 10,000 with annual HIV testing through community health campaigns. The intervention is antiretroviral access with optimized linkage and retention and streamlined care delivery for all persons living with HIV. And in the control arm, ART will be offered according to country policy. All communities will have optimized evidence-based scale-up of HIV combination prevention. Our primary objective is to determine the magnitude and durability of community-wide ART at all CD4 cell counts and HIV incidence, and secondary objectives are to evaluate effect of the intervention on health, education, and economic outcomes. So our health outcomes, this is not a complete list, but to list a few, the cumulative 3- and 5-year HIV incidence in men and women over 15 years of age, overall mortality and maternal and infant mortality, mother-to-child HIV transmission, AIDS events, population HIV RNA measures, HIV drug resistance, tuberculosis, and we'll also be looking at non-communicable diseases. One of the really major focuses of the Search study are both economic and education evaluations. And there are two essentially pillars of this approach. First, we're going to be looking at cost and cost effectiveness, the cost of the programs, offsetting savings, cost effectiveness based on dailies averted. Then also we'll be doing an assessment of the effects of universal antiretroviral therapy on individuals, households, and community, using multiple socioeconomic outcomes measured in longitudinal household surveys. So we're calling our study design an ECHO, an efficient community cohort design. And there are three key elements of our design. We're performing a baseline household community level census on every single household in our study communities. In all of the communities, there will be an annual community health campaign that used unique identifiers to link individuals between successive years of the intervention and also as they access health care at the local health care facilities. We'll be doing tracking and HIV testing of a random sample of individuals who do not participate in the annual community health campaigns. Search is is many of the trials that you've heard about today already, is a terrific venue to ask implementation science questions. This is just one that we'll be looking at is the HIV care cascade, and we're not just going to be limiting it to HIV. We're also going to be looking at diabetes and hypertension, as we will be diagnosing that at our community health campaigns. We will have longitudinal measures throughout each step of the cascade, from time of HIV testing to linkage to retention of care. We'll be looking at clinic efficiencies. We have a very robust social science agenda. We'll be looking at provider attitudes and behavior and how they affect the care cascade, patient social networks, and also patient satisfaction in terms of the care that they are receiving. This cartoon is a schematic of the search study design. So we have our 32 communities that are randomized to the intervention or the control arm. Then we have a baseline census done in all the households in the community, and then we have repeated community health campaigns obtaining individual level linked data, and then ascertainment of non-returnees. So we've been working on search for over 2 years now, and we've presented some of the results of our pilot studies at meetings, but just briefly to review the building blocks that we've been working on with search. First and foremost, starting with our country partnerships and community engaging. We did ethnographic mapping of the communities in order to identify the communities and to pair them. We performed a census to identify and follow our study populations. We have piloted 2 community health campaigns in a community that will not be participating in the main trial, which of course to demonstrate that we could find persons living with HIV and demonstrate that we could link them to care. We've developed a finger prick HIV RNA assay that we're using now at our community health campaigns. We have a pilot study of the efficacy and cost of treating people with high CD4 cell counts. And we're incorporating into the government health system, strengthening and help them meet targets for both HIV and non-communicable diseases. As mentioned, we have robust measures and metrics of employment and education, which we have been piloting over the last 2 years. So our community health campaign is an event that's put on that is supported by the community, and it is a high throughput event. We see approximately 1,000 individuals per day, and we offer prevention and health services for children and adults. And at the campaign, people are offered HIV testing and counseling. We do point of care CD4 cell counts. We do finger prick viral loads. They have blood pressure measured in order to diagnose hypertension. We do glucose measures from finger prick assays to diagnose diabetes. We also do rapid tests for malaria and offer malaria treatment on site for those who are diagnosed with malaria. And then we offer deworming for the children and also bed nets and condoms at the exit of the community health campaign. As we go through search, each of these community health campaigns is going to have the personality of the community. The first community that we were working in, it was very important to them to include diabetes and hypertension. One of the goals that we had, is, which you had heard also from Project Accept, was really to destigmatize HIV testing. We've published the results of our first community health campaign. We found adults with HIV at 8% prevalence. About half of those were new infections, about 12% hypertension, and diabetes 3.5%. And as has been shown before, when you go out into the community, you identify people with higher CD4 cell counts. And we wanted to have proof of principle that, in fact, we could find people early in their HIV disease. We also looked sequentially at our 2 community health campaigns in an area where they were ramping up HIV treatment. And we looked at a variety of metrics in terms of viral load at the community level. And just to draw your attention to the first line, our first campaign, 37% of the individuals in the community had viral load suppression. And at the time we did the second campaign, 55%. In this pilot community, which as I mentioned will not be in the larger search study, all the individuals now are being offered ART, regardless of the CD4 cell counts, and we'll have some more measures of that in about 6 to 9 months. I also mentioned that we have a pilot study ongoing treating individuals with high CD4 cell counts. The treatment regimen that we're using for this, as in the SEARCH study, is Truvada and efavirenz. We use a streamlined health model with nurses, healthcare workers doing symptomatic screen with MD backup, infrequent lab monitoring, and short wait times through the clinic. One of the questions was, we didn't know how many people would be interested in taking therapy. We found an extraordinarily high uptake of people interested in taking therapy, and we asked them why, and 90% said it'll keep me healthy, 52% said it allowed me to continue working, and you can see the other reasons here. This is in a very rural area in Uganda. We've had excellent retention in this study. I'm not showing the results here. We'll be submitting them to a conference in the fall when we have the full 48-week data on viral load suppression, but the viral load suppression has been extraordinarily high in this pilot study in individuals who are asymptomatic with high CD4 cell counts. We don't have the t-shirts, but I really like those t-shirts. We're going to have to get them for our patients. In terms of employment measures, this was actually a slide that also Mike had shown. Our economists, as part of our pilot studies, we were evaluating what can we show from a workforce participation the benefit of keeping one's CD4 cell counts high. And this was really quite extraordinary, that those individuals with CD4 cell counts greater than 500 worked nearly 1 week per month more than those with lower CD4 cell counts. So these are just pilot data, but we are going to be measuring this in the SEARCH study. And when we embarked on this study, we recognized we had not only to convince the ministers of health to invest in more HIV treatment, but also the ministers of finance. So where are we in terms of SEARCH? The study has started. We had public randomization events, similar to the ones you heard about in Uganda. We started our first community census on April 2nd of this year. We have real-time data reporting, which we're going to be using throughout the study. Excellent community uptake. Our first community health campaign starts in June 1st, and we anticipate the Uganda sites will be starting between now and the fall, and in September the sites in Kenya will start. So with that, I'll thank all of the many, many collaborators.